Hi, everyone. Welcome to the 2021 Virtual Conference on Lead and Healthy Housing Issues. I'm Dan Price, and I teach at the University of Houston in the Honors College. And first of all, I want to say thanks to Steve Weil and to all the fine folks at the Office of Lead Hazard Control and Healthy Homes for providing the entire conference and for inviting me to speak here today. I've actually spoken once before, and some of you may have seen me live at Omaha in 2018, I think it was May. And there I was talking about community health workers and the possibilities for reimbursement for work that they would do in things like asthma mitigation and ways that that could be paid for by healthcare payers like insurers because they were providing value to the system through preventative care. The reason that I had first met the folks at the Office of Lead Hazard Control and Healthy Homes was because we were involved in a project about community mapping of the social determinants of health. And one of the things that's happened in the intervening years is I've really thought a lot about what the problems were with that model and with the ways in which, in some significant sense, the maps prevent us from thinking as well as we could think about the possibilities that communities have, especially their strengths. The maps are really good at showing where weaknesses are, but they don't show strengths very well. And in order to start showing strengths, we also have to think about where those strengths lie. And my feeling has always been that community health workers, and along with a lot of other frontline workers, are just truly inspiring people. They've committed their lives to advocacy, and that there's something about this process of advocacy that we can help support through better approaches to data, and that if we can support that and collect that data in the right ways, we can come up with better policy. We can get policy that supports strengths. We can have homes where people feel like they can trust the system and that they can work towards making the system as a whole better. That's a big picture, a lot to hope for, but I think that these are really fundamental questions. It's a slightly different way of thinking about what the social determinants stand for in people's lives and in policymakers' decision making. And I think that today, what we'll do is we'll look at a couple of the bigger questions going into the data collection, and then we'll talk about specific tools that I think we could use to empower community health workers across cities and states, and across the entire United States, actually, to collect better ideas for what types of policies would address barriers to people getting to where they want to be, as opposed to characterizing the weaknesses that people already have. So, again, I'm Dan Price. You can contact me at dprice2@uh.edu. I'd love to hear from you. And I'm the director of the Community Health Workers Initiative there. If you have any kind of questions about community health workers and ways in which we can provide training, we do that for everyone. Let's just turn to the maps. Let's start with the United States to kind of get an orientation for ourselves. This is from openstreetmaps.org. They do a lot of good work, nice alternative to Google. And then if we look at the Gulf Coast, see Houston there on the left and the crook of the arm of Texas, I think that there's a lot to be said for understanding Houston as part of the southeast of the United States. It's really a place that was formed by an identity with the Gulf Coast and with the type of plantations and slavery that you associate with places like Mobile, Alabama, more than Dallas or Austin. Now, what happened in the development of Houston was the 1900 storm that destroyed Galveston caused Houston to seem a lot more reasonable as a port. So it developed a lot of industry along the port because Galveston was no longer playing that role. And in 1901, Spindletop happened over in Beaumont, just south of Beaumont, which is very close to Houston, doesn't have quite as good of a port, and a lot of the oil started going through Houston. A lot of the businesses were placed there. And what's happened is that there's been a huge development of Houston around the center that used to touch on the port going to the west. That development was mostly of folks with means moving away from the industry. The older houses, the kind of working class stock of housing, really was built around the industry that originated from the port and then developed in concentric circles. Of course, the people who were making the moves didn't experience this as a series of concentric circles. They experienced it as a choice and a constrained choice. They had different options depending on their race and their income. They had different decisions to make depending on how much they were concerned about the pollution at the port, how much they wanted a certain type of suburban life. All of those things were trajectories, there were pathways laid out in front of each individual. What we're looking at right now is a tool that is paid for by real estate interests to show people who are thinking about moving to Houston how to think about the neighborhoods. Now, they've done something, race isn't one of the ones that they show up top to their credit, but it's very easy to nowadays take all of the data from the census and automate it at the census tract level. This is much better than we used to get 5 or 10 years ago. It's free. Every city in the United States is covered, and you can do things like look at the racial components of Houston and the metropolitan area and how it's grown, and you can clearly see that the white population follows that pathway out to the west, and then after a while started doing the ring suburbs. The African American population, the black population, is green here. The darker green is the more concentrated percentages, and the Hispanic population is in the tan. The problem is if you look at the income map produced by the same folks, you'll see a very similar pattern on the neighborhoods as you saw with race. This map helpfully actually shows the top 1% as well as a breakdown, and the top 1% is overwhelmingly in the Anglo population. But I think the more important thing is when we start thinking about this as options people face, constrained options, then the policy that you want to talk about is how the constraints come into place. It's not just a question of creating more income, although income helps you navigate the constraints. It's understanding where the constraints are and understanding how those have been put into place with historical overlays. And then part of the key is that the data scientists are also facing lots of choices. They've got to choose what colors to use and where to put the breakpoints when they're looking at quartiles. I wanted to put up an example from the public health realm. This is a competitor to the tool developed with the Office of Lead Hazard Control and Healthy Homes that I talked about earlier. What we see here is them trying to account for the skew, and a skew means how much the distribution is shifted away from a perfect bell curve. And they're trying to account for the skew by showing you the distribution of income on the right-hand side there. And what happens is that median, as opposed to average, is already meant to account for the skew. And then they have green for the top 50%, and then have given 25% on the bottom and 25% in the middle bottom for yellow and red. And the idea there is that you'll see the distinctions very much more so for people that are below that median level than for people above, where you don't really see the distinctions at all unless you dive down into it. That's because they think that the policy decisions should be about those kind of poorer regions and understanding where that poverty hits. That's a set of assumptions that we have to look at as well, exactly how we think about what counts as poverty, what counts as the problem that we're addressing, when we're looking at these types of maps. There are several important things to remember when reading these maps. One is, you're choosing these colors based on different comparisons. I've gone to their default, which is the Texas census tracts, which means that the green is 50% of all of Texas, not all of Houston. So it's not 50% of the area that you're looking at. That actually gives you more information, but it's a little bit harder to read. What we're looking at right now is the children living below the poverty level, which you would expect to track pretty well with the median household income, but isn't exact. So you've got the general backward C shape that we've been seeing in all of our maps so far, but you also have more of a skew, more of a tail on the right-hand side that's going up very quickly. You've got several neighborhoods with 80% of the children living under poverty, and you've got more neighborhoods than that even that are 0% children living under poverty. And that kind of variation is very hard to represent. Life expectancy is one of the most common things that we measure, and it's been in the news a lot since some researchers have been able to really demonstrate how large the difference is based on neighborhoods. And so this is a map that shows that neighborhood difference, with the total difference being a possible 20 some years. But what happens, as you can see from the distribution, is that most of it's fairly even in the middle. And what you want to really understand are those tails, and then to see more generally how it distributes around the neighborhoods in Houston and how that would overlap with things like we were already looking at, such as race and income. What's interesting, of course, is that you're seeing the same backward C. If we go to high blood pressure, we see a very similar pattern, not exactly the same, but a lot of that's artifacts of the way in which the data is reported. High blood pressure is actually coming from a modeled expectation value that is generated from population characteristics. The differences that we might see between Houston and New Orleans and Mobile aren't going to show up in that model in the ways that we might hope. There's some things that they do to try and correct for localities and states that you're in, but you're not going to see the kind of fine-grained detail that you would if you were actually going door to door and asking people how high their blood pressure was. That this overlaps with adult obesity is of no surprise at all, but we're seeing the same pattern again, that backward C. I do think in some ways it's more interesting when you don't see the pattern. So throwing up here for just a second, adult cancer, which the different data source for how they're getting that kind of those values. But what's happening with adult cancer is that you're also seeing a larger trend demographically that older people have more cancer, that the relatively wealthy population is living longer means that there's also possibilities for more cancer, although the people that are in the top 1% have less of the cancer. It's not an easy thing to read. You have to go through lots of different permutations of what is the possible combination that we're really trying to understand. And the way in which the community of researchers that are interested in the social determinants of health has really moved is that they've started trying to think about indexes. What does it mean to have an index that captures all of the things that go on in our thinking about health, our thinking about community strengths, community weaknesses, et cetera, et cetera. The problem with the indexes is that you end up with things like the social vulnerability index. It's different mapping companies will show it in a slightly different way. And what you see with the social vulnerability index is not something that is unfamiliar to us. We're seeing kind of the same overall pattern that we're seeing with everything else. There's a kind of overlay logic to all of the problems that we're understanding here. Even worse, there's a deprivation index that combines a bunch of these same measures and gives you a kind of averaging score. With the deprivation index, you see the same pattern. I have thought a lot about what type of effect this has on our students when we teach it, because it takes a long time to teach all of the different problems that you might have with the representation, all the choices that you're making as a data scientist, and all the ways in which that implies choices about your interpretive framework, and therefore what kind of policies you're going to support. But what happens with the students is that there's a real tendency to try to jump to a conclusion about the whole. And I think that this happens with popular newspaper coverage as well. And you get a what I call poverty sucks response. And that goes from different ways. Some students are empathetic and they want to help the people who are poor. Other students say, well, gee, I'm glad I'm not poor. A couple students will always respond with something like, well, gee, poor people must be really mad to have all these things piling up. I better go buy a gun. The responses are not what we hope. The way in which we look at it, when we look at these maps piling up one after another, is that we're looking at a determined population. We're looking at people who are suffering under a set of weaknesses, and we're saying, gee, that just really builds up. How are we going to respond to it? One step at a time, but it doesn't look like policy does it. If it is policy, we have to do something like provide more income for everybody. How would that work? What are we thinking about from a policy side? It becomes really quite a mess on the policy side. And so what I wanted to suggest was that we should back up and think about this data side again. You'll notice that I've been talking a lot about opportunities. And there are ways in which these opportunities are faced by individuals, and you can aggregate over those individuals if they're things like racism or lack of economic opportunity for geographical reasons. You can talk about people facing common barriers, but each of those barriers is slightly different and has to do with different desires that people have for their own lives. What kinds of things they want to see achieved, what they consider comfortable, what they consider the right direction that they want to go for the rest of their lives. All of these questions are really hard to represent in a poverty sucks map. We have to think about, in some ways, the same data, but from a different framing. So the suggestion I have is let's start by asking a little bit more about the paths that people are on and how that intersects with what we consider healthy communities and healthy homes and the strengths of those homes. The other thing to think about is how we're representing each individual in the situation, whether or not individuals feel like they're well represented, whether they feel like their own sense of self-determination is involved. And the first step that some people have taken and that we ourselves have also tried to follow is to think about that individuality differently when we produce the maps. A fellow named Dustin Cable, who's a professor in the University of Virginia, made a bit of a splash in the mapping world in 2013 with a map that assigned a dot and a race to every individual in the United States based on the 2010 census data, which he spread around according to where people actually were living. And you can zoom in, and we'll zoom into Houston here, and you can see that there are just a lot of ways in which the geographic boundaries that are enforced by roads, other types of industrial activity, show up in the fact that no one's living in certain places, and then that the boundaries between areas are not quite as stark as they are with the other maps that we're looking at. There's a little bit more porousness, and there's a lot more of kind of, that's interesting. Asians live here, but they've never really been the majority in that census tract, but there's clearly a concentration. We've got all sorts of ways in which those types of things can emerge when you're just looking at the map, but it's hard to summarize. It doesn't make the data analysis much easier, but it does allow you a different thinking about what it is you're getting from the map. What we did, we called ours SAM because Sam is Sam Houston on a first name basis. And the idea there was that we would go and actually get household addresses and supply population characteristics at each household so that we could look both at this type of large scale, all inside the loop, what's the racial distribution look like in general. And then as we zoomed in, we could start saying, what are the other characteristics that are here that we should look at? What are the things that are really going to be important as we go forward, thinking about the various ways that we can analyze how interventions in health can produce better outcomes. So for our example, we looked at asthma and we looked at ER usage. Asthma is really actually a very difficult thing to measure, because what you're measuring usually is not underlying asthma, but uncontrolled asthma. And uncontrolled asthma has an entirely different set of problems. You've got different ways in which the costs are associated with it. There's a lot of things that you have to think about in terms of that measurement. In any case, we were borrowing other people's projections and some of the data from the city and the state, and we came up with ways of looking at asthma across the city, and then zooming in to an area around the third ward that I'm going to talk about in just a second. The third ward being one of the traditionally African American areas of Houston and right close to U of H. As we look at what's happening in the third ward, we see that an intervention that changed by just a few percentage points how many people were having to see the emergency room doctor could actually make a big impact in the raw numbers of people that were helped. That kind of sense that you're looking at raw numbers, we think also gives you a better way of interpreting things that is less likely to be affected by arbitrary decisions on where you've put the quartiles and where you're making the binning decisions, assigning your colors. The problem is, even with this type of specificity, you're not making something that's easier to interpret. And one of our underlying arguments is that the purpose of the map shouldn't be a kind of dead tool where you have a product that is interpreted either correctly or incorrectly by an expert who then tells the correct interpretation to a policymaker who then implements it either correctly or incorrectly. What should be happening is that we should start thinking about ways in which these maps can work on an individual level, but also capture the trajectories people are on, the pathways that they're on. And that requires a different thinking about what it is that we're collecting as data from the very beginning. Now, one of the reasons we haven't taken this live is that we've had a lot of difficulty figuring out how to represent people who live in apartments, both because they're stacked on top of each other and because we don't know the floor layouts of each of the apartments. It's not public information. We want to look at one place in particular, though, and that's right in the middle here. You see only one dot for all 560 apartment complexes. That dot just has a lot of stacks in it. And in that place, it's called CUNY Homes. It's named for a person named Richard Wright CUNY, who was, according to the New York Times, the most prominent African-American politician of the 1890s. He is almost completely forgotten, including by the people who live in the apartment complex named after him. That apartment complex is public housing. It's in fact the oldest public housing in Houston, founded in 1938. And a lot of African Americans were moving into Houston from East Texas, from their farms that they had grown up on and their parents had grown up on, because the violence against blacks was intense. And the period between 1900 or 1890s really and the 1960s had lots of lynchings, lots of other types of violence that were just short of lynching, and there was a feeling that coming to Houston could give you some respite from that, just like people moving to the north were hoping to escape the racism. that I think is better to see as constraints on the individual freedoms of the people that are trying to move forward. It's a pathway that people are on, and the racism is keeping them from fulfilling that pathway. If we talk about opportunities and ways in which people can take advantage of the opportunities, I think we can make better policy. Some of you may already know the name CUNY Homes because it's the place where George Floyd spent his childhood. And it's made a lot of news as an example of failed policies. It's a place where the policing is notoriously bad. The people who live in the community feel like they are victimized by the police, but also need the police. It's not a simple kind of being anti-police. They feel that the system has largely forgotten them, and there's a complete lack of trust in institutional answers. They don't feel like the government's on their side, and because of that, they also don't feel like taking vaccines or participating in preventative health is necessarily in their best interests. They have separate ways that they deal with everything. And I think that that's a very interesting approach to their own strength. And one of the things that we did was we started a community health worker class there in order to get both the pre-professional students at U of H and the residents at CUNY thinking about what types of projects we could do together to build back that sense of trust and to better achieve the type of behavior change goals that are at the heart of all of the preventative medicine. So how do you get people to actually participate in diabetes prevention programs? Well, you have a person from the community teaching that class to other people that they know instead of having an expert come in and say, well, why don't you believe what we believe? When I was at university, when I got my PhD, I was taught this. This is what you should believe. And that type of argument doesn't really bridge the trust gap. And so finding a new way of understanding where people are and where people want to be, and then tapping into that is critical to behavior change. So just over a year ago, we started a new collaboration with a data partner called Patient Care Intervention Center. It's founded by Kalal Mahata and Dave Buck here in Houston to take advantage of better data resources in coping with the problems of superutilizers. Those are people who often are homeless, costing the system lots of money because they're going in and out of jail, in and out of the emergency room, in and out of residential treatment centers. And if we could just get them care coordination and help them lead happier lives, would actually save money for the system as a whole. And that kind of win-win was what they were hoping for. It turns out to be fairly difficult to make parts of that case stick financially. And what we did was we said, you know, we have a slightly different business case and a slightly different way that we want to approach this. We want to talk about folks who are in public housing, folks who are not necessarily super utilizers, but who still aren't getting the best preventative care, and they aren't getting the best utilization of resources. They already had a system set up that really closed the gaps between service provision and the medical system, with lots of access into the costs that the medical system was incurring because of people. And we also had ways in which we could model future outcomes based on primary care and the readings that they have on sugar and things like that. And we could talk about ways in which we could save particular insurers money by coordinating that care and helping people see the value of the behavior change. The embedded community health workers could be better at that particular part. Now, that's an ongoing and funded research project when we have community health workers across the Houston area working with us, collecting that data, and we hope to have some results soon. The other part of it, though, is that the system that the PCIC, Patient Care Intervention Center, was putting in place was values-based. And that meant that instead of trying to sell services that you already had in your pocket to a person who was in need. You started talking to a person and saying, well, where are you trying to go with your life? What are you trying to get done? What are the values you have? And then writing down what are the barriers that keep you from being able to get completion on your values. No judgment about what those values are. They could be anything. One of the favorite examples is a lot of homeless folks really love their dogs and will not go to a shelter. They won't take a dog. And people who don't have that kind of affection for dogs don't understand, but it's really very important. How can you maintain that sense of value for people who are trying to take care of their entire family, that want to get a job? It's a similar dynamic. You're on a pathway. You've got barriers that you're running into. So we decided that we could modify a little bit the use case and just a little bit the database collection process and get a much better picture of what types of barriers people are running into. Now it requires a little bit of scale, and so we're hoping to get in the thousands of people responding over the course of the next couple of years in the Houston area alone, so that we can get a full picture of how these pathways that people are on are being blocked by the barriers that they're facing. At that point, we should be able to generate policy that is responsive to where people want to go and the barriers they're facing, as opposed to judging that they haven't gotten to a place that we thought they should be, and then saying, why aren't you following what we asked you to do? That's the difference, we think, between a trusted system and a system that frankly doesn't even deserve trust. So how does this all tie together? The point is, there's a lot of conversation about how people don't trust the government. They don't trust the system anymore, if they ever did. And the reason for that is that there's no sense that you've got a shared project with the system. If we can get embedded CHWs to occupy a place where they're sharing a community and a sense of advocacy for each other, it's not that they create a great sense of communal well-being in some magical way. What happens is that people start working together. They work together, creating more opportunities for each other, and that virtuous circle is enhanced by having a sense that everybody's voice can be respected. So advocacy is not advocating for particular political parties. Advocacy is saying, oh, my friend needs help with the doctor. I can advocate for that person. I myself need to advocate in the face of the constraints I'm facing. I need advocacy to happen at all of these different levels. That's part of what it means to move forward effectively, to not just want to move forward, but to actually be able to. That we have a system in place, at least potentially, that could capture how those barriers are faced across populations, means that we could change the language that we use for talking about government. Government need not be just a set of bureaucratic forms that you have to fill out. It's not the regulations that you have to be a certain type of person to qualify. It could be that the regulations, the policy themselves, are generated by an understanding of what directions people are trying to go and why they're being thwarted in that effort to move. We have both a big vision and a lot of ways that there are just small steps leading towards getting there. The small steps are those individual acts of advocacy and creating a network that is able to track and hold accountable people that are part of that network so that they can get paid and they can be sustained in their activities, and that the insurers and the other health payers can be confident that they're paying for something that's worthwhile. Those pieces don't change the fundamental vision, which is the embedded CHWs don't need us to talk for them. They just need help creating efficacy through advocacy. That means getting better tools for advocating, getting the training that helps you understand how to advocate effectively, getting the training that helps you understand how to coordinate care. It means understanding how the resources that are available in a neighborhood can be best responsive to where people actually want to go, as opposed to being like a menu of things that people might choose from if they were passive and just kind of waiting around for things to happen. That fundamental change in how we understand what it means for people to be engaged with the system makes it possible for the system to work better. If we can track that, then we can create return on investment at all these different levels and create better systems for better outcomes using people who are embedded in the system, embedded in the community, and who can have their voice effectively brought to the level of meaningful policy change. We are actively looking for people who want to collaborate with us, people who'd be interested in seeing something like this happen in their town. There are a number of people who are doing data projects. We don't claim to be the only people doing data projects at all, but we do think that there's something original in that concentration on what it means to be embedded, what it means to create trust, and to still see it as potentially a business opportunity, something where we're sustainable and can be scaled. We can imagine things like the local health departments that are running lead abatement, having a tie-in with lots of nonprofits, all of whom are not talking to each other enough as it is, and a bunch of the community members not really utilizing those resources properly. Having a small group of community health workers from an otherwise marginalized community can really make a difference in how people use the resources and can make a difference in how people see their relationship to the government. We think that it's a great opportunity. We're looking for people who want to discuss further how we can make this work. And I can be reached by anyone at dprice2@uh.edu. I'm on my email all the time, of course. And I want to conclude by saying thank you again to Steve Weil for the opportunity to speak to everybody. And I hope that everyone felt like this was worth their time. Thanks very much for coming, and have a good day.